conjunction with the Royal College of GPs in Wales and also Velindre and Velindre Oncology Academy. We've got a list of speakers for you this evening on fundamentally pancreatic cancer and an update of what primary care needs to know, when we need to refer, and how they are managed and how they are best supported in secondary care. So I'm Elise Lang, I'm a GP in Cardiff, and one day a week I'm the Velindre GP lead, and together with my colleagues, Dr. Mick Button and Fiona Rawlinson, we have been coordinating these webinars for you. Just to say, we have started recording. We are going to be recording tonight, and that will be available then for people to listen on playback and catch up at other times. And so please do share with your colleagues. Mick, I know you just wanted to say a couple of words before we get going.
Yeah, thanks, Elise. Thanks, Fiona, and thanks, everybody. Really looking forward to this evening. It's part of a series of webinars that we're doing, trying to break down some of the barriers, improve communication, understanding between primary care, secondary care and tertiary care, so we can all work better to look after patients with cancer. I always find them informative and helpful. I'm very grateful to everybody who's given up their evening for this. As Elise says, it will be recorded so people can watch it afterwards. Do come in with questions. Want to make it interactive and helpful for you. And really looking forward to hearing what the speakers have to say. I think it'll be hosted on the Velindre Oncology Academy website afterwards. And thanks to the Royal College of GP team as well, who've helped kind of promote, organise and support the meeting. So really good to see people coming together, kind of diverse group of professionals, just exactly as it should be, looking after patients, trying to do the best we can to give them the best care that we can. Thanks.
Fabulous. Well, let's make a start. And the first speaker tonight is one of my GP colleagues as a cancer lead in Wales, Dr. Ruth Corbally. If you joined the previous meeting, you'd have seen Ruth speak there. She's a local expert on a number of issues, but today we're tapping into her knowledge on pancreatic cancer. So over to you, Ruth, please.
Thank you, Elise. I don't know about expert, but GP with interests. But thank you for that introduction. So I'm just going to see now if I can share my slides. Can you see those now?
Yes, we can.
Yes,
You just want to share the presentation because we can see your list on the side as well.
Yeah, I've just put in slideshow on. Can
Perfect.
you see it now? Can you just see the main title slide now?
Yeah, perfect. Thank you.
So thank you for asking me to come and get involved with this talk on pancreatic cancer this evening. So as Elise said, I'm Ruth Corbally and I work clinically as a GP in Abergavenny in Aneurin Bevan, and then my cancer lead as a GP is with Powys Teaching Health Board. So I'd like to start this with a bit of a patient story. I'd like to introduce you to a really delightful gentleman, John, who's 92. And I'd like to start, I suppose, telling you about his story just to keep us grounded and remember that patients are at the centre of everything that we do. He also illustrates a couple of points then that I want to make further on. So starting with John, I initially sort of looked back to how he presented earlier before we diagnosed the pancreatic cancer to see whether there might be some clues earlier on in his journey, but I was pleased that there weren't really. So he was very fit, lean gentleman, very active, goes out and about town on his own, does his own shopping, looks after himself, very independent, really, really lovely gentleman and all his wits about him, but not a frequent attender at all. And he did come in September 2023, just with some bit of constipation, which resolved with Laxido and nothing further was thought about it. And he wasn't seen for another 6 months in the practice when he attended with just a single episode of dizziness, which wasn't investigated at the time as it wasn't recurrent symptoms. So it wasn't until he then presented in May of last year with some shortness of breath, and he'd noted some recent weight loss that he was investigated. And that revealed an iron deficiency anemia, which led to a fit test, symptomatic fit test, which came back positive at 29.6. So high enough to be positive for a symptomatic fit test, though would have been negative on a Public Health Wales screening test. In Aneurin Bevan, a positive fit test then leads to an automatic referral through to the urgent suspected cancer pathway for colorectal cancer. And his colonoscopy only revealed some diverticular disease. But due to his symptoms, a CT scan was requested and the practice was asked to perform a CEA and CA 19.9 blood test for him, both of which actually turned out to be normal. though unfortunately the CT was not. And the CT revealed a malignant neoplasm of his tail of pancreas. And this was discussed at MDT in August of last year, and he was deemed not for curative therapy but for palliative care, and we were given the advice that there was no need for Creon. He then presented in January 2025 next to the practice. He wasn't seen in between, but came in January. He's not a complainer, but was saying that he was more symptomatic, was struggling a bit more, feeling generally a bit more unwell and a bit of discomfort, and more advice was sought from secondary care at that point, and the advice that was received back was that the St David's nurses option, so palliative care, was going to be the best option for him, and there was the comment on the feedback that Creon was unlikely to be of benefit. So he didn't come back to the practice until May of this year, and that was actually the first time that I met John. And at the time he was really quite struggling with abdominal pain, diarrhea, feeling just generally lethargic, unwell in himself. He was trying Oromorph but finding that it wasn't effective. And at the time then we had a chat about Creon, and he was amenable to trying it. So we started him on Creon. I actually bumped into his son then later on that week, who was in great form and turned around saying it was amazing that his dad's life had been completely turned around and he was back to his usual self. And then I saw him later on in June, and just some quotes from the notes that I wrote then when I saw him in June was that he was feeling better all round. He was sleeping better, he had almost no pain, he was eating better, feeling generally better in himself, and said that he'd had a helpful chat with Pancreatic Cancer UK, who'd sent him on some further information on enzyme replacement. Coming through to July, he'd had a few problems with diarrhea, so we did increase his Creon dose at that stage, but he was completely pain-free, so was keen to reduce the morphine dose, so he did reduce his MST down to once daily. Coming through to September, he was still doing really well, still doing all his own shopping, walking up and down town, going to his sort of social groups, playing Scrabble or other sort of similar social interactions that he has on a regular basis. He had some mild intermittent pain in his epigastrium, which he said Oromorph on an occasional basis was very effective for, and he had most days without pain. So the point there really is that although this gentleman is 92 with pancreatic cancer, which was actually metastatic at the point of the initial CT, he's had months and months of really good quality of life and stayed really active. And it's only really in the last few weeks that he's reducing his energy levels and is no longer doing his own shopping, but still out and about and keeping up with his social groups. He has had a few issues with sort of lower abdominal pain, which actually responded well to some antibiotic treatment because we knew that he had diverticulosis, and has had some right chest wall discomfort, though quite mild, and edema. So just I've spoken to him about how much we should be doing investigations at this point, and how much just to sort of wait and see how things go. So discussing his edema, that it was quite likely that it'll be down to a dropping in his albumin at the moment, but that there's nothing that we can actually do about it if we find that he has a low albumin. So we've decided not to do any further blood tests. But he was keen to have a chest x-ray to understand whether that niggle in his chest wall might have been related to his cancer progressing. And unfortunately, the chest x-ray has come back showing that he does have likely extensive disease throughout the right side of his chest and most of his left lung field as well. But he continues to stay reasonably active and is being seen regularly now by St David's nurses, and we're continuing to look after him. And he's not a complainer, but we're trying to get him to tell us when he has any symptoms so that we can do something about them. So just looking at what symptoms are associated with pancreatic cancer. So abdominal pain, as you would expect, upper epigastric pain, which often then may go through to the back and cause back pain with it. In patients with known diabetes, there may be a sudden change in how well they're, or deterioration in control of their diabetes, which isn't explained by a change in their diet or change in their lifestyle. or medications, or in a patient that you wouldn't expect a new onset of diabetes. So to be aware of those patients and to think pancreatic cancer is a possibility. If you have pancreatic cancer of the head of the pancreas, then you may get the more classic presentation with jaundice, dark urine, those pale floating stools, nausea or vomiting, a reduction in appetite, anorexia, and unexplained weight loss. As you can see there, sort of unexplained weight loss is actually the only symptom that John had when he presented to us initially. And the community health pathways does also mention weakness, particularly in the proximal muscles. So there are many predisposing factors for pancreatic cancer to bear in mind when we're looking after our patients. If you are male, then you're at an increased risk of pancreatic cancer, or if you have a high BMI, some socials, smoking or alcohol abuse. Diabetics are at an increased risk of developing pancreatic cancer, so it is looking out for those patients with diabetes whose control goes off unexpectedly. Patients who have a history of pesticide or chemical exposure, or if they have a family history of a first-degree relative of pancreatic cancer, then they are also at increased risk. Or if they have a history of chronic pancreatitis. There are several hereditary cancer syndromes which are associated with pancreatic cancer to be aware of. And there's the Peutz-Jeghers syndrome, which are patients with dark spots on their hands and face, which is associated with GI polyps. And that's mainly associated with an increased risk of bowel or breast cancer, but is also associated with increased risk of pancreatic cancer. There's the BRCA1 and 2 genes, which we're most familiar with for the increased risk of breast and ovarian cancer, but also to be particularly aware in those patients to think beyond breast and ovarian cancer, that we know that there's an increased risk of prostate cancer, melanoma, and also pancreatic cancer with the BRCA genes. The familial atypical multiple mole and melanoma syndrome, or FAM, is, as you would expect, associated with a large number of unusual moles. People with these have a higher risk of melanoma, but also of pancreatic cancer. And then we also have the Lynch and Li-Fraumeni syndromes. Not that many of us will have patients with any of these, apart from maybe the BRCA ones. So thinking about these patients, then examination and investigations in primary care. Often they may come in complaining of some unexpected weight loss. So if we check their weight and BMI, if we have a previous weight on their records, then it'll give us an idea as to whether they've had a significant weight loss. But it also gives us a baseline then for going forwards and monitoring their weight. Are they feverish? Do they have jaundice, which we'll come into later as well, being particularly associated with head of pancreatic cancers? On the abdominal examination then, can you feel any mass? Is there tenderness, particularly hepatic tenderness, or any distension or ascites? Also be mindful that, as with any patients with cancer, they're at higher risk of a spontaneous deep vein thrombosis or DVT. The initial investigations that are useful for these patients would be a full blood count, kidney, liver, clotting, the HbA1c, looking for diabetes or diabetic control, and the CA 19.9, which is associated with pancreatic cancer, though our patient John, his CA 19.9 was normal. Full blood count's particularly important to pick up a microcytic anemia associated with iron deficiency, so that we can give iron replacement therapy to counteract that. And the HbA1c, either to look out for new diabetes developing so that we can manage that, or to make sure that we are maintaining good control of patients' diabetes if they are already diabetic. And then the investigation of choice in primary care is an urgent suspected CT, chest, abdomen and pelvis with pancreatic protocol if you suspect pancreatic cancer, though we will come through. Now, actually, next slide is the NICE guidance. So with the NICE guidance, if you see a patient that is over 40 and has jaundice, then the advice is to refer straight away as a suspected cancer pathway referral. But do consider that urgent direct access CT done as an urgent suspected cancer CT It does say or urgent ultrasound if CT not available, but I would hope that most of us have access to CT scanning now, particularly if we are concerned about the potential for pancreatic cancer. And it's mainly in people aged 60 and over with weight loss and any of the following symptoms. So diarrhea, back pain, abdominal pain, nausea, vomiting, constipation, or as we've mentioned, new onset diabetes. But I would think beyond just people aged 60 and over, as thinking of other patients that I've had with pancreatic cancer or people that I've known with pancreatic cancer. I have seen people down in their late 30s and 40s, particularly who have been overweight. So not always a fan of the age cutoffs. But the national optimal pathways, that I don't know if people are familiar, this is a set of optimal pathways that have been set out for Wales for the different cancer sites. This is the one for pancreatic cancer. It's actually a draft, so it's an update for the pancreatic cancer national optimal pathway, so probably not to be shared at the moment. And the main bit, I know you can't read it all, I've just blown up the top left-hand bit because that's what's relevant to us at the very beginning in primary care. The rest is to do with the rest of their pathway through diagnosis and through to treatment. I'll leave that to Guy to talk about more maybe. So if you look at that GP direct access CT as per the NICE guidance, or if you see someone who's over 40 and jaundiced, then it would be appropriate to refer straight on an urgent suspected cancer pathway for pancreatic cancer. And what's been added into these the draft for this national optimal pathway update is just don't wait for your local NDT discussion or tissue diagnoses before referring on, and it does give the contact there for referrals. But you'll note in both of those GP access ones, we have some numbers in there, that 4, 5 and 7. So the numbers that are added into the national optimal pathways relate to the person-centred care aspect of looking after these patients. So number 4 is that health optimization, which I will talk about now. And it's making every contact count with our patients when we see them to optimize their health. 5 is prehabilitation, because we know that if we improve people's physical and mental health from the point of suspicion of cancer, that the healthier and more resilient they are, they may have more options for treatment, and they'll also tolerate those treatments better and have better clinical outcomes. So it's a good way to empower our patients also, to give them something that they can do to help their outcomes while they're undergoing cancer treatment and on their pathway. But tonight isn't about prehabilitation, so I won't bang on about that. And then number 7 then is about capturing patient-reported outcome measures, or PROMs, which we are keen to understand our patients' perception of their pathways. So as I mentioned, do think about optimization of your patient's health when you're referring them as urgent suspected cancer pathways. And this is for all patients that we refer for any cancer sites. Think about their comorbidities and have them as, I suppose, as fit and healthy as possible for going into the journey that's ahead of them. For pancreatic cancer in particular, we're encouraged to think about iron deficiency anemia. So to do that full blood count, and if they do have an iron deficiency anemia, to start iron replacement therapy to counteract it. And then from the point of view of diabetes, patients with pancreatic cancer are at an increased risk of developing diabetes, so be vigilant for that. And those who are diabetic already, because we know that having diabetes is an increased risk for developing pancreatic cancer, optimize their management and make sure that we're looking after their diabetes as well as possible. And I will talk about some resource for that now in a further slide. And also talking about thinking that pancreatic enzyme replacement therapy, or CREON, as it is so important to patients, but I don't want to go into it in too much detail because I know that Hannah is going to speak about it, though I had to include this slide because I love this slide. But really this is just banging that drum that PERT is for everybody, whether it's curative or palliative patients. Please do consider starting CREON. And if you don't feel that confident around Creon and starting it, Pancreatic Cancer UK is an amazing resource, both for patients and for professionals when managing people with pancreatic cancer. November is actually the Pancreatic Cancer Awareness Month, and I see that they do have get your free symptoms awareness packs now, so it is encouraging people to go onto the Pancreatic Cancer UK website and spread the word about pancreatic cancer to raise awareness. But as I said, they support professionals as well as patients. There is a direct number to talk to a specialist nurse for pancreatic cancer, and they can give fantastic advice and support both to professionals for prescribing Creon and also to patients who may be taking it and have concerns about other symptoms as well. They put on a lot of educational events and they have a lot of educational resources. I've just taken some snippets there of some of the ones that they have up on their site at the moment around the dietetic management, treatment that's there if you want to know more about it, symptom management for people with pancreatic cancer, and also the management of diabetes is for patients with pancreatic cancer. And they've just started a new series of webinars on that, and the first few are available to watch back on the Pancreatic Cancer UK website. They also have an option to sign up to their newsletters as well, and then they send you regular emails with more information. So I think of all the charities, it does actually provide a lot of information and support for professionals and patients with pancreatic cancer. So just a few key messages then coming away from that. Beware of pancreatic cancer in patients with gastrointestinal symptoms. There is an overlap. Thinking back to John's case, the only gastrointestinal symptom that he had was a short duration of constipation that was many months before he developed any weight loss or anything else, which I don't think we could have picked up on at that stage. But it is thinking that if someone comes in and they've got iron deficiency anemia and weight loss, like John, he ended up on the colorectal urgent suspected cancer pathway. And there's so much overlap between the different gastrointestinal cancer site pathways that it's easy for patients to end up on the wrong one first. So do have pancreatic cancer in the back of your mind, please, and think whether a CT is needed. The other point is that it's often a vague presentation. Like John had shortness of breath and some weight loss. So often then when our patients come in with a vague presentation, it can be difficult to find the right path to go down. So a couple of things to be mindful of is Jess's rule. Do think if it's a patient's third time presenting and we don't have a good cause for their symptoms, think again, go back, start from the beginning, look at their history, are there further investigations that we should be doing to look for an answer, or should we be referring them on? And if you have a patient that you are worried that it could be cancer, but they don't fit the criteria for an urgent suspected cancer pathway for a specific site, and then do remember the rapid diagnostic clinics to refer through to the RDCs because they are a great service. The NICE guidance does remind us to tell patients that they are being referred on an urgent suspected cancer pathway. So please do discuss that with your patients. It's important for a number of reasons. One, if a patient knows that cancer is in the differential for what they're being referred for, then hopefully they will be less likely to DNA their appointments. It also means then that when they do come into secondary care, they have a little bit of preparation before coming through, and it's not going to be too much of a shock when they're in secondary care then if further investigations are warranted quickly. It helps if a patient understands already that they are on an urgent suspected cancer pathway. Thirdly, do consider PERT, please. PERT is pancreatic enzyme replacement therapy, or Creon is a common one that's used, as well as referral to a dietitian for all patients with pancreatic cancer, which Hannah will talk to us all about in a little bit. And then Pancreatic Cancer UK. And do think about signposting patients through to Pancreatic Cancer UK. Having that telephone number for the specialist nurse can be really beneficial for them. And as John found then, he was sent out further information on the pancreatic enzyme replacement therapy, which he found helpful, as well as there being lots of educational resources and advice through their website. And I will try and stop sharing. Sorry,
Thanks.
I've talked for a long time.
Thanks very much, Ruth. Really, really relevant to primary care. There haven't been any questions in the chat specifically to your update as yet. So people, please do feel free to write comments in the chat and add any questions. I mean, I think, working in primary care, the two most recent, cancers of the pancreas we've diagnosed in our surgery would be related to HbA1cs going off acutely, and so being aware of that and weight loss is obviously really paramount. And I'd agree with you. The other one, the one I was involved with earlier in the year was a younger chap as well. Born in 1970, so 55. So outside of that age range that NICE would sort of look at, but sort of symptoms that just weren't quite. I wasn't quite happy to settle with without doing the CT. And in Cardiff, when we do the CT and trying to work out what's going on, we have options of surgical and non-surgical referrals if we think these patients are suitable for referral. And our surgical candidates go down the M4 to Mr. Guy Shingler and his colleagues in Swansea Bay. So Guy's kindly agreed to talk about pancreatic cancer from the point of view of a surgical perspective, although not laying on heavily on the surgical side this evening, Guy. But thank you very much for your update. And like I say, folks, if you want to put questions in the chat, Guy's happy for interruptions if relevant. Otherwise, we'll do them all at the end. Thank you. I assume you're working out how to get off mute, Guy. Perfect. We can see your slides.
Is that all visible? Can you see all the slides or just the actual presentation?
Just the first presentation one.
Perfect. That's working well. Excellent.
Thanks, Guy.
Sorry, you didn't need to hear me all talking to myself as I was trying to work out how to make it share screens. Hi, I'm Guy Shingler. I'm one of the consultant pancreatic surgeons for Morriston. Ruth's done an amazing talk on a lot of the stuff I was worried I might not be covering thoroughly in this, so that's brilliant. It's dovetailed in nicely there. So I'm going to talk a bit about the National Optimal Pathway because I was sort of heavily involved in its inception. I mean, our pathway is essentially recreated what we were already doing with our resectable patients, and then adding in a second pathway on the side of that for all the palliative side of things as well. I mean, at the end of the day, a lot of to-do is made of all the resectable patients, and getting them through fast track surgery and all this sort of thing. But actually, that's only 15% of the people who actually present with pancreas cancer. The vast majority are never going to have an operation or can't, are never going to get there. A lot of them present, with stage 4 disease from the outset, and they're not suitable for surgery. So any of the pathways that are set up, while it's important to get people to theatre quickly, it also has to take care of the palliative side of things. And I think that's part of what the revision of the next iteration of the pathway is got a bit more things on the holistic approach and the palliative side of things, but also the neoadjuvant side of things. So in terms of surgery, we're moving more towards treating people with chemotherapy before their surgery rather than afterwards. But we'll go through. Won't touch on that too much because it gets a bit technical. It's not necessarily what you guys really need to know for your day-to-day. So I'm going to start with some relatively new news. It's another one of my hats is being the lead for the National Pancreatic Cancer Audit in Wales and the Welsh lead for that. And it's the second year that's been published now. The data we published from Wales is slightly limited because of the fact we have 2 cancer databases and we were only allowed to use one of them to put towards the actual audit. We don't gather any data on a number of the KPIs, which are things like PERT usage, which would be quite useful to know who's getting PERT and who isn't, whether or not a patient's discussed in an MDT, and we also don't know anything about whether or not people are seeing clinical nurse specialists and things as well, which is all quite useful things. But we do gather data on some of the other stuff. So to compare things between England and Wales, as you can see, I said a lot of people present with stage 2 disease. In Wales, 2/3 of patients, 65% of patients present with stage 4, that's metastatic pancreatic cancer. It's slightly less in England, and that's open to interpretation as to why that is, and we'll go into that in a bit more detail. But probably we're not diagnosing people fast enough, or people don't come forward with their symptoms as readily. I don't know exactly what it is, and I think that probably needs to be dug into a little bit more to find out why that is. Patients in Wales also tend to present with a poorer performance status than patients in England as well, and that also limits access to treatment. Waiting times. In England, the median weight from GP referral to diagnosis, so point of suspicion to diagnosis, is 20 days. Wales, it's only 21 days, and I think that's possibly a reflection of the fact that we have RDCs and had them before. I think before England, so I think we were using the RDCs quite a lot, and I think that's probably helps with that. We also have, I think now, certainly in Swansea, certain parts of Wales have reasonably good access to open access CT, and I think that also helps to speed things along a bit. In terms of getting people to treatment, there's more of a lag in Wales. Patients wait up to 90 days between their initial presentation to the GP and then to their actual getting their first definitive treatment. I mean, that I'll explain why in a minute, but that's far too long. For the patients who actually receive treatment, again, in Wales, we are behind England in terms of getting patients from the diagnosis to treatment. And I think that is probably going to, and interestingly though, that's not then reflected in the actual survival figures. I'm not clear why that is at the moment. If you look at this, the 30-day survival in England, there's not a lot of difference between England and Wales. And at 1 year, the survival is exactly the same for all comers. This is all patients with pancreas cancer, whether or not they have surgery. It's not exactly clear at the moment why that treating people less results in the same outcomes. One thing to say is that the audit is staggered. So the data from England is 2021 to 2022, whereas the Welsh data is 22 to 23. So we're not exactly comparing oranges with oranges here. Although it doesn't seem like we're doing too badly behind England, when you look at the rest of the world, the United Kingdom is not in a great place, really. We have one of the worst survival outcomes for pancreatic cancer, and that's been the case for the last 20-25 years now. Things are not improving, and that's and if you look around the world at similar populations, Australia, New Zealand, Canada, we don't have the same survival outcomes as the rest of the world, and that's something that we need to work on. So pancreas cancer is actually a relatively rare cancer. It gets a lot of noise because it's quite a bad one to have. It's one of the most lethal cancers, but it's relatively rare. There's approximately 15 per 100,000, and that reflects in 926 cases, about 500 cases a year in Wales. And what that means for you as general practitioners is you'll probably only see a new pancreatic cancer every 2 or 3 years. And that's what makes it difficult, is if it's some things you're treating day in, day out, you see a lot of. Pancreas cancer you won't see much of, and it's difficult to sometimes to know what to do with the patients when they present to you. And I think that's why the pathways are really important, because it gives everyone hopefully a more standardized treatment, and it gives everyone a reference as to what they should be doing when they find a patient with pancreas cancer, however they present. And as Ruth's already said, they can present in many different ways through different pathways. The headline figure here is that 50% of patients with a new diagnosis of pancreas cancer will be dead within 3 months of their diagnosis. Okay, you just think about that. So I said earlier that the median time in Wales from point of referral to treatment is 90 days. So loads of patients aren't getting to their treatment because they're just dying before they get there, essentially. And that's why speed is important in this. Even for patients who undergo surgery and go on to have their chemotherapy after the 5 years and 15%, you will see better figures and it's difficult.
Are we all just Guy? I think you may be glitching. Is that for everybody?
Yeah, I was just about to say I've lost Guy as well.
It tends to present quite late. The symptoms are often pretty vague, as we've already said. It's quite an aggressive cancer. It can be quite aggressive. Interestingly, anecdotally, certainly, patients, they are often the more indolent it is. Certainly, your patients tend to have a more aggressive course than the older ones. I'm not sure if there's any data supporting. It's in the wrong place, your pancreas. Here, it is wrapped around some of the most important blood vessels to your bowels. It sits on top of the aorta by the IVC. It's next to the kidneys. It's a weak, squidgy thing. It doesn't have a good capsule around it, so it's slowly, very rapidly.
Guy?
Blood supply, because it's a very active endocrine and exocrine.
I think we're losing you, Guy.
Oh dear. At what point did you lose me?
Just before this picture came up. I just wonder if you drop your camera, it might help just with the bandwidth. So you might be a bit clearer if you take your picture off. Sorry.
Is that better? Can you hear me now?
Yeah, I think so.
Yeah. Okay.
Sounds a lot better now, guys. Sorry. Yeah, as you changed slides, it really started glitching. If you could just go from there again. Sorry.
No problem. Probably one of my kids has started streaming TV downstairs or something. That's okay. So where did I go to? I was on why is it so lethal? So as I say, it's badly positioned at the back. It's wrapped around the important things. It's got a great blood supply, great venous drainage, lots of lymphatics around there, and it metastasizes very early. The tumor itself is chemo-resistant, and actually the way it functions, it's immunomodulatory itself. It suppresses the pancreas tumor itself, produces various chemicals that will affect the immune system and reduce its effectiveness. So the tumor itself sort of protects itself, as it were. And also the effect of a pancreas with a big tumor in the middle of it compounds the immunocompromise through uncontrolled diabetes and malnutrition. So it's a sort of a perfect storm really of a tumor, and I think that's why one of the reasons it causes so much problem. So what can we do to improve outcomes for these patients? We've established that it's horrible and the outcomes aren't great at the moment. There's a few different things. First of all, the speed of diagnosis. If we can be diagnosing patients faster, that's clearly going to get us to get into treatment sooner. As I've said already, the proportion of patients there's a large proportion of patients who won't actually survive long enough to get to treatment. So if we can get to them faster and we can manage their complications better, we should be able to get them to get to treatment, and that's not happening at the moment. There's also an element of trying to speed things through the pathway, and as I said, treating the side effects should help with that as well. Okay. I've just managed to start up the wrong presentation here, so that's part of the issue here. I'm going to drop out and go back, if that's okay, because this is an earlier version, which is missing quite a lot. Sorry, guys.
That's okay. We can see your slides, but obviously they're not the ones you want to share. Then
they're not the ones I was doing earlier. So I'm just going to apologies. That is not what I wanted.
After our last meeting, we were saying how nice it is when you can do these in a function room or a restaurant with some food and company. But IT's helpful where it works, isn't it? But then when you get glitches, it becomes a problem. But
yeah.
Just while we're waiting, if there are questions, drop them in the chat, or there'll be time for some discussion and questions at the end if people want to come through. So do be thinking. Are there any key questions at the moment, anybody?
Yeah, there we go. Right, can we see that now?
We've just got a blank screen, Guy, or at least I have just a white screen.
There's text appearing now?
No.
Oh my God's sakes. Right, okay. That's really frustrating. Right. Right, is that any better?
It's just loading, I think, at the moment. We can see your... No, it isn't sharing, Guy, sorry. It's just a white screen again.
That is... Okay, I'm just going to come out of T. Oh, I can't even go back to what I had before now. That's really frustrating.
Would you like us to move on to...
Yeah, no, it's
Hannah?
Sorry guys, this is not ideal. Yeah, no, it's yeah, yeah, do you want to do that, and I'll come back to you, because that's...
So, yeah, sorry to catch you off guard, Hannah, but
Yeah, no,
I know you
it's,
had some important updates to do on kind of dietetics management of pancreatic cancer. So I would be grateful if we could, for the point of view of kind of everyone's evening, move on to your presentation and then let Guy do his update at the end, and any questions can be added to the chat. Is that okay?
Yeah,
Thank you.
okay. I'll just do the whole, I'm going to try and share my slides thing. Right, what's everybody seeing? Can you see my first slide?
No, we're seeing you and a lovely picture of Swansea.
Oh no.
Yeah.
Hang on a minute.
It looks very different to the weather outside this evening.
Why is it doing that then? Oh gosh.
Just while we're loading up, can anyone in the audience, has anyone had any recent experiences of diagnosing or looking after someone with pancreatic cancer? And maybe have that thought, save it for later. We've got your slides now, Hannah. Thank you.
Okay, nobody's seeing my notes there, are they?
No, we've just got
It's
a
just
slide
the
up.
one slide.
Okay. Right, well, thank you for inviting me to speak today. My name's Hannah. I'm the lead pancreatic surgery dietitian based in Morrison Hospital at the Welsh Regional Pancreatic and Biliary Surgery Centre. I've got a bit of a whistle-stop tour for you today, so I'm just going to sort of jump straight in. So a little overview of what we're going to be talking about. So we're going to do a very brief revision of the exocrine pancreas, touching then on PEI and PERT and some PERT troubleshooting and a bit of addressing the PERT shortages, and then jumping into malnutrition in pancreatic cancer and a little about long-term micronutrient monitoring, and then just a little service outline. So this is just a little revision. I wasn't sure what the level would be like, so it's just a very brief overview of how the exocrine pancreas is stimulated under normal circumstances. So we know the exocrine pancreas is producing digestive enzymes, and this is comprised of lipase, amylase, and proteases. It's also producing bicarbonate, which is raising the duodenal pH. And in between episodes of dietary intake, we've got a basal level of enzyme secretion. So if we look at the numbers here in the interdigestive phase, we're looking at around 1,000 units per minute of lipase. Stimulation of enzyme secretion then happens in response to nutritional intake. So the sight and smell of food and the presence of food in the stomach starts pancreatic stimulation. But the most powerful inducer of enzyme secretion is the presence of the acidic chyme passing into the duodenum. So then we see enzyme release rising rapidly to reach peak output in around 20 to 60 minutes. So you can see here the numbers of lipase units per minute in the early postprandial phase, around 3,000 to 6,000. And then following peak delivery, secretion is reducing to a stable rate for around 3 to 4 hours. We're producing somewhere in the region of 2,000 to 4,000 units of lipase per minute, after which it's returning to interdigestive levels. And the amount and duration of enzyme release is relative to the caloric content of the meal. So I just wanted to do a quick revision of this because it's useful to keep these numbers in mind, I think, when we're moving forward and we're talking about enzyme replacement. So anything that interferes with this chain of events can disrupt normal digestion, causing PEI or pancreatic exocrine insufficiency, leading to maldigestion. And the result of this is that we then get malabsorption of nutrients, and then we get nutritional deficiencies. So we've got two different types of PEIs, primary and secondary. So with primary PEI, we're thinking about PEI as a result of a loss of the pancreatic exocrine tissue secondary to pancreatic disease. So for example, solid tumours which can destroy the surrounding tissue, resulting in reduced capacity to produce enzymes. Tumours causing obstruction to the pancreatic duct, or pancreatic surgery resulting in a reduction of the exocrine tissue, or altering the physiology, which can affect the normal mechanisms of enzyme secretion. In secondary PEI, then we might have a loss of pancreatic exocrine stimulation or activation. So intra or extrapancreatic tumours causing obstruction. In gastric surgery, gastric resection, or duodenal resection, we can be reducing the areas of stimulation for the exocrine pancreas. And also we're altering the anatomy, which can change transit time and cause asynchrony of enzymes and the food bolus. And then, for example, in jejunal feeding, something that we might do quite commonly in hospital, we're bypassing oral, gastric and duodenal sites of enzyme stimulation. And also we can see asynchrony of feed and enzymes as well. So these are just a few examples for you of different types of PEI. So a globally recognised definition here then of what is PEI. It's a reduction of the pancreatic exocrine activity in the intestines at a level that prevents normal digestion. And we know that the incidence of PEI is high. It's very common in both resectable and unresectable pancreatic cancer, affecting around 66 to 94% of patients at presentation. But it's also progressive. In unresectable pancreatic cancer, is estimated a 10% reduction in function per month. So if your patient with pancreatic cancer has normal pancreatic function on diagnosis, it's quite likely that it's going to subsequently develop. Given the high prevalence, testing isn't required and treatment is recommended. And we have the NICE guidance, which tells us that all patients with pancreatic cancer should be started on enzyme replacement therapy. I would say we need to be considering the location. So the closer the tumour is to the head of the pancreas, the greater the risk of PEI. So what we would tend to do is prescribe for all head of pancreas and neck of pancreas location tumours. If they are symptomatic, if it's in the body of the pancreas or the tail of the pancreas, we are looking to prescribe if they present with symptoms. And the sorts of symptoms that we are looking at. So in very severe malabsorption, we've got presentation of frank steatorrhea, so loose, watery, yellow or orange stool. Often I hear patients say that their stools are pale or clay-coloured. Stool might float and be difficult to flush away and be oily. Often patients report an oily sheen on the water. But this is severe malabsorption, and we can have also more subtle symptoms that might indicate mild or moderate malabsorption. So some of these symptoms, could be attributed to any number of things, but can be a symptom of malabsorption in pancreatic cancer. So we want to be considering If the patient's got increased stool frequency or volume, any bloating or flatulence, which can be particularly offensive in smell, any urgency or incontinence, any abdominal pain related to eating, any dyspeptic symptoms, generalized nausea and abdominal pain, any weight loss despite good oral intake, any vitamin deficiencies, in particular A, D, E, and K, and any new episodes of hypoglycemia in patients with otherwise stable diabetes, indicating that perhaps carbohydrates are not being absorbed correctly. And it's really important to be mindful of masking. So the overt symptoms, although we're looking for them, they can be masked by opiates and other constipating medications, antidiarrheals, and also subconscious fat reduction. If patients have put together subconsciously that these foods that are high in fat are causing them to have symptoms that are really unpleasant, then they might naturally reduce those without meaning to. And obviously, we need to have fat in our diet for it to be present in our stool. So patients naturally putting themselves onto a low-fat diet can mask malabsorption also. So the cornerstone treatment for PEI is PERT, or what we would most commonly be hearing referred to as Creon. It's associated with an improved nutritional status, improved quality of life, and it may even improve survival. Consent is incredibly important. The number of patients that come through and see me and have not consented to, or they're not aware of the fact that PERT preparations are porcine based, it's very high. So there is no suitable vegetarian alternative. There are some on the market, but they're not evidenced and doses are extremely low. So if patient comes to you and they're taking these, then we need to be encouraging them not to and switching them on to PERT. From a religious point of view, patients should be counselled that Jewish and Muslim faith leaders have consented to the use of PERT for medical needs, as there's no suitable alternatives. So PERT contains a mixture of lipase, amylase, and protease. So we're trying to mimic what the pancreas is producing. And the starting doses here, which I know have already been referenced. So with a meal, we're looking at 50,000 to 75,000 units. So you would, typically prescribe that TDS. With a snack, we're looking at 25,000 to 50,000 units. So that you could be prescribing that PRN, and that would be to be taken with any snack in between meals. Also with a snack dose to be taken with any milky drinks and with most nutritional supplements. Patients often ask, what is a snack? It's pretty subjective and it does depend on the type of food that they're having. But as a rule of thumb, around about a handful of food, and anything more than that, we're kind of thinking that's treating it more like a main meal. The rule of thumb with milky drinks is that if it's more than 50% milk, then we're taking a snack dose with it. So for example, tea and coffee with a splash of milk, it's not needed. But something like a latte or hot chocolate, then absolutely we'd be taking a snack dose with that. And most nutritional supplement drinks also require PERT for absorption. So there are some specialist products that are peptide and MCT based, and they can be sipped over time without PERTs, but likely you need to have a dietitian involved to advise you on that. So just then a little bit about the different PERTs available on the market. So Creon is the one pretty much everybody has heard of, and it's our first line in Swansea Bay. And it comes in 3 presentations. We've got 10,000 unit capsule, a 25,000 unit capsule, and micro, where 2 scoops of that equals 10,000 units. And the units is referring to the amount of lipase that's within 1 capsule or one dose. So, thinking back to what we talked about earlier with what the pancreas is producing, these numbers, they're pretty low in comparison to what your pancreas is normally producing. We've also got Nutrizyme 22, and they produce a 22,000 unit capsule. And then we've got Pancreas B, and they produce a 8,000 unit capsule and a powder, whereby 1 gram is equivalent to 25,000 units of lipase. So it's already been mentioned that we need to be starting PERT early on in the patient journey. So it can be started at point of suspicion. It can be prescribed in primary care. We don't need to be waiting for these patients to present at the tertiary centre to get these prescriptions going. So we want to be trying to improve prescribing rates in primary care. So we've got this this reference down here, this study, which shows there's a wide variation in prescribing rates in different settings. So we know prescribing is highest in centres providing pancreaticobiliary surgery compared with non-surgical centres, which makes complete sense. But the doses here, the difference here is, it's twice as high in a surgery centre. We've got variations between resectable and non-resectable cancers. So you can see nearly 75% there versus 45%. Variations between curative surgery and palliative surgery. So nearly 97% versus 75%. And then there's variations in the rate of prescription amongst those awaiting surgery as well. So we've got 40% pre-op, and that increases to almost 91% post-op. So we want to be improving these rates, basically. So if we are getting those prescriptions going in primary care, we need to be giving the patient some sort of first line advice on how to take it. So the sort of basics would be that we want to be swallowing the capsules whole without chewing. They should be swallowed with a cold drink. They must be taken with drinks at more than half milk. We've talked about that. And we do advise patients to stagger the dose evenly throughout the meal. So often they'll come to us and they are taking them all at the start. And I think it depends on the patient. If you sense overwhelm, then maybe it's best just to get them going on it. But if they seem to be taking the information on okay, then we usually advise them to spread it out throughout the meal. And this enables it to mix better. And it's also sort of mimicking the way that the pancreas is producing continually throughout the meal. Larger portions or fattier foods might require more enzymes, and that's okay. So takeaways or meals out, or perhaps a longer meal such as a 3-course meal or a buffet, they're likely to have to take more in that scenario than they would on an average day eating their food at home. So we're aiming to educate patients to enable them to adjust their doses independently. And patients, education is not a one-off. These patients are going to require ongoing education. We go over Creon or PERT advice with them every time we have contact with them. So for yourselves, a referral to a dietitian is absolutely going to help with this, because we can provide that support for them ongoing and take that off you, really. Patients will often say to us, what happens if I take too much? Because they're quite anxious. They're particularly about the numbers, 3 or they might be taking 3 with a meal, and then 2 with a snack, then another 3. And by the end of the day, say they're taking 20 to 25 capsules. The numbers are scary, 25,000 units. So patients are really anxious about it. So we just want to be reassuring them there's no maximum dose. We want to be adjusting the PERT to suit the diet, not adjusting the diet to suit the PERT. So reassuring the patient that there is no toxicity concerns here if you take a bit too much. Now, if you are taking more Creon than your body needs, it can occasionally lead to some anal irritation, but realistically, I don't see that happening very often, and you would need to be taking quite large amounts. So I think the message to the patient is don't worry too much. If you're not sure if you should take 2 or 3 or even 4, then just take the higher dose. The risk of taking a little bit more is much lower than not taking enough. However, with that in mind, if you get a patient who's up to 100,000, 150,000 with a meal, we're not seeing an improvement in the symptoms, then we want to start thinking about differentials, comorbidities. Could it be bile acid diarrhea? Could it be SIBO, infection? Or even is there another diagnosis going on, IBD, celiac disease, etc.? So we want to consider the PEI, but we also want to be thinking about everything else as well, because we know things can run alongside. And then it's very important for patients to know that the enzymes are heat sensitive, so not to store near heat source. They could be keeping them in their kitchen cupboard above the kettle for all we know. So making sure that they are storing them correctly. Men tend to put them in their pockets if they're going out and about, and obviously body temperature is much higher than 25 degrees. Don't keep them in the car, especially in the summer, not swallowing with a hot drink, and not sprinkling on food. We don't want to be chewing up the enzymes in our mouth. That's going to cause some problems in your mouth and not be very pleasant. So a little bit of troubleshooting for you. So if you're going to read one paper about how to manage PEI and PERT, this would be the one I'd recommend. This is the consensus statement for the management of PEI in the UK. It's very practical, and there's a flow chart here which is really nice for helping you to decide where you need to be going next. Now, do bear in mind that this flow chart is for all PEI, not just PEI secondary to pancreatic cancer. So it's also taking in pancreatitis as well. So just bear that in mind. So if a patient comes to you and says they're having some swallowing difficulties, this is quite common. The capsules are quite large. Patients will often say, well, I can't swallow it. What should I do? So we can advise them to open the capsule. Inside the capsule, there is enterically coated mini microspheres. These can be emptied onto a spoon of acidic food, and that is very important that it is acidic. The enteric coating on the mini microspheres dissolves in an alkaline environment, and it's there to protect the enzymes from the acidic environment in the stomach. So we don't want to be dissolving that enteric coating before it's hitting the gut. So an acidic food being something like apple puree or apple sauce, fruit yogurt, chutney, tomato ketchup, that kind of thing. And then telling them to swallow without chewing and then rinse their mouth just to make sure there's no damage to the oral mucosa. Tolerance issues. Patients sometimes say, or doesn't agree with me. We need to pick that apart a little bit. Is it just that they haven't got the doses right and they've got some symptoms of malabsorption? But sometimes if we think that it is genuinely a tolerance issue, then we can just try an alternative brand. And we have had patients switch off Creon onto Nutrizyme 22, and for some reason they tolerate it better. Sometimes patients will say, well, I can't take the PERT, it makes me constipated. So they then get sort of anxious about taking it. But we need to counsel them that it's most likely not a reaction to the Creon. So constipation can obviously occur alongside malabsorption. And if a patient is malabsorbing, it's almost treating the constipation. And then if we then treat the malabsorption and prevent it from happening, it's revealing a constipation that's kind of been there all along. So what we need to do is educate the patient on that, treat the constipation and continue the PERT. However, if constipation is already there before commencing PERT, or before dose escalating, then address the constipation first, because obviously adding in PERT is going to make the situation worse. Somebody might say, oh, well, the PERT's given me high blood glucose, so I'm not going to take it because it's causing my sugars to go high. Again, it's counselling the patient on the fact that this is not the PERT doing this. It's improved absorption of carbohydrates. So it's actually a good thing. It's showing that they're absorbing. And we don't want to restrict their diet. We want to be continuing with the PERT, but then referring to the diabetes team. Maybe they need to commence on medications or insulin, or if they're already on something, they might need to increase their doses. And then they're on PERT, but the symptoms are ongoing. So we can talk about dose escalation. We can try a PPI to raise the pH to help the enzymes work better and a little higher up in the guts. And then we can be considering a differential diagnosis also. And, you know, at any of these points, refer to a dietitian, because we can really help to sort of dig down into these problems and come to a solution. So when you do refer to a dietitian, or if you're thinking about dose escalating, these are some of the things that we want to be thinking about. So again, from the consensus statement, so we want to be looking at weight changes in relation to their intake, any functional changes, any low micronutrient status, any new hypos that might suggest not absorbing carbs, looking at stool frequency, texture, that kind of thing, dyspeptic symptoms, considering any medications that could be masking. And then a dietitian also would be looking at 24-hour dietary recall with relevant PERT dose to assess adherence and ratio of PERT to the nutrition. We look at any food avoidance and any avoidance of fat-containing products, and also the overall nutritional adequacy of the diet. So it's quite a lot of things to consider. And again, knowing the amount of time that you have with your patients, refer to a dietitian and we can help you. So moving on to the stock shortage, I know that this has been ongoing for a little while. So the ongoing, there's a supply issue with Creon, and it's ongoing, estimated to be until the end of 2026. There is a position statement here, which was published and updated now in 2025 from all of input from all of these bodies. It is now possible to import preparations from Europe. So in England, they're using a product called Pangrol, but we haven't, or I haven't yet had to import anything. So we're managing to get around the issues currently. So in the paper, it talks about how to prioritise PERT for your different patient groups. So we don't want to be switching patients off Creon 25,000 onto other products if we can avoid it, because we're causing knock-on effect stock issues on these other products that need to be prioritised for people who actually really need that product. So, for example, Creon 10,000 and Creon Micro for children and infants and dysphagia. Nutrizyme 22 for those who can't tolerate Creon, and Pancreax V powder shouldn't really be given orally. We're going to be putting it down enteral feeding tubes. So again, in this paper, they on one of the first pages, there's helplines listed. So if patients are coming to you and saying that they can't get their Creon or their Nutrizyme, there is helplines here that you can direct them to for them to get some advice on areas with recent deliveries, and also just encouraging them to phone around their local pharmacies. They may have stock one day and not the next. It's very fluctuating as the Creon stock is sort of dripping through. So just briefly going through then malnutrition in pancreatic cancer. So it's present in 70 to 80% of all pancreatic cancer patients. Got some definitions here of cachexia and sarcopenia, but I'm not going to go into that with you. And then I wanted to talk about the impact study as well. So I'm not sure if anybody's aware of this or not, but it's a retrospective study of advanced pancreatic cancer patients looking at whether baseline sarcopenia or early loss of skeletal muscle mass may impact on prognosis. And they found that loss of skeletal muscle mass significantly associated with worse overall survival. At baseline, 73% of patients had sarcopenia. 33% of those patients had a BMI of over 25, and then 35% of those patients with early loss of skeletal muscle mass of more than 10%, they had a BMI of over 25. So weight and BMI by itself not really going to be helping us in this scenario, because muscle mass is important in this patient group, and we'll see why. So early loss of skeletal muscle mass of more than 10% was associated with a worse overall survival, showing that loss of skeletal muscle mass has a negative prognostic role in advanced pancreatic cancer. So the prevalence of muscle loss in pancreatic cancer, 47%. It's second only to head and neck cancer in prevalence, so very high. We've got the obvious consequences of muscle loss: reduced quality of life, fatigue, weakness, increased falls risk. But it's important to remember that skeletal muscle is not just structural. It's also involved in communication between muscles and the body's organs and other tissues, and in regulating the immune system and the inflammatory responses. So a low muscle mass can actually lead to reduced inflammatory regulation and reduced tumor suppression. So pretty important to have your skeletal muscle there. We also know then low muscle mass leads to poorer clinical outcomes. And if we talk about dose-limiting chemotherapy toxicity as well, we know that skeletal muscle is involved in distributing, metabolizing and clearing chemotherapy meds, which are calculated based on body surface area. So if we have two people with the same BMI, they can have a significantly differing skeletal muscle mass, but still receive the same dose of chemotherapy. So patients with a lower skeletal muscle mass are actually twice as likely to experience dose-limiting chemotoxicity. So these are really, really serious outcomes, and this is why we're talking about malnutrition and muscle loss in this patient group. Treating malnutrition, incredibly multifactorial. All of these factors around the outside and many more will be impacting and causing the malnutrition in the centre. Treating malnutrition, it's more complicated than just prescribing nutritional supplements. It's about overcoming the barriers to the nutrition. So that's what we do, dietitians. We'll investigate and address the barriers in order to treat the malnutrition. So again, refer to a dietitian. We've got more time to spend sort of digging into these with our patients and hopefully addressing those barriers and overcoming the malnutrition. Long-term micronutrient monitoring. This might be something that some of you have come across. It's a bit of a problem at the moment. So the recommendations here from the consensus statement are, this is what we need to be monitoring. So patients who've undergone curative treatment, we're looking to monitor all of these. And then in palliation, we're looking at being a little bit more sensible here. This recommendation comes out with all of my discharge letters, and it does cause a problem because some health boards aren't allowing the ordering of some of these biochemistry tests in primary care. That is a problem. However, the recommendation stands. So all I can suggest is that maybe we need to be escalating on a case-by-case basis to provide evidence of a need to be able to request these in primary care. I'm not able to keep hold of them long term. We're a small service and we wouldn't be able to keep hold of all the patients coming through in South Wales. That would take our time away from the patients going through their treatment. Additionally, I wouldn't have a consultant to request the bloods because I can't request them myself. I'm a dietitian. I wouldn't have a consultant to report back to. It's just not practical for me to be making these requests. So if it's a problem, escalate it, and hopefully at some point it will be addressed. Where you can order the biochemistry, but you're personally not feeling very confident or you're a bit uncertain over what to do with interpreting the results, this has also come through as a bit of an issue. So if the micronutrients are low, but the patient's asymptomatic, probably best just to refer to your local dietetic department. They can assess the PERT compliance and usage, whether it needs to be up titrated, and assessing the patient's oral intake. And then after intervention, sometimes past, rechecking, see if it's made any impact. If micronutrients are low and the patient is symptomatic, do all of the above that we just talked about, but we need to be replacing. So if you've got a local chemical pathologist who can advise, great. If you don't and you need some support, then you can come to us. That's fine. I've got somebody that I would liaise with, a chemical pathologist, who advises me on a patient-by-patient basis. So I'm open to receiving emails about what we should be doing next. A little outline of our service. So this is our service pathway. I can send this out to anybody who's interested. So this is me 4 days a week, and I've got 2 dietitians working with me who are 3 days a week. One is in a static post and one is in a rotational post. So every sort of 8 or 9 months, I'm training up somebody new, and hopefully we're improving knowledge of pancreatic dietetics. We've got some inclusion criteria, so we will see patients under the pancreatic consultant who are undergoing surgery to the pancreas, duodenum, jejunum, biliary system, who present with PEI and or risk of malnutrition. Patients under the pancreatic consultant who are undergoing treatment of complex pancreatitis, but we won't see mild to moderate acute pancreatitis, and we don't see chronic pancreatitis if they're not undergoing surgery, and we don't see pancreatic cancer patients who are not undergoing surgery. So we're very much a surgical service. Any pancreatic cancer patient not undergoing surgery should be referred to the oncology service dietitian or the local dietetic service where oncology dietitians don't exist. And these are my contact details. We've got a generic email address. Please email us with questions. We're very happy to answer them. Phone number for our department, and if you're really desperate, this is my bleep number, but ideally not that, because I'll be out and about on the ward and I'll probably say I need to speak to you later anyway. So that's the end of my presentation. Thank you for listening.
Thanks, Hannah. That was hugely helpful and really valuable and insightful. I think that there's so much that primary care need to be aware of that perhaps we don't do enough of, and the point of seeing only one in every couple of years, the sort of keeping it in the front of your mind, but knowing that services are out there is hugely helpful. I think certainly the last time I pestered Guy was about Creon for a patient who was Jewish, and I didn't know that it was all porcine based, but she did, and she raised that as an issue for herself, and obviously had to understand that was an option she had to take. So little hints like that are also hugely valuable. I'm really conscious of time, so I don't quite know how much Guy's got left to cover with his interrupted talk, but we've got 15 minutes booked with you guys for this evening. So Guy, if we could pass back to you to sort of wrap up your part of the talk, and hopefully maybe leave about 5 minutes or so at the end for questions. Is that okay with everyone?
Yeah, no problem. Right, let's see if I can get this to work any better. I had to completely leave you guys and come back because I wasn't getting any pictures or anything coming through after that. So let's try this.
Just while Guy's coming in, maybe everybody have a think about any patients with pancreatic cancer that you've cared for or been involved in their pathway, and how the talk this evening relates to that. If there are any kind of problems that we've covered or any things that you would like to ask the faculty that we've got when Guy's finished. So just have a think about your own personal practice. Thanks.
So Guy, we're on the right slide, so hopefully we'll move on to the next one with the anatomy slide, and all good to go. Thank you.
Great. So yeah, so apologies guys, I've just been reminded why I don't use my work laptop for doing presentations, because it always stitches me up. It's just managed to delete my actual presentation, so I'm working on the slides as they were at 9 o'clock this morning. So what can we do to improve outcomes? We've already established that pancreas cancer is a nasty disease. It is difficult to treat. It's difficult to get the patients to treatment because they progress so rapidly. So speed is of the essence, essentially. So speed of diagnosis. I mean, Ruth's already talked about getting a CT early, which is exactly the right thing. I think in terms of getting patients through the pathway quickest, probably if you can start off with a CT scan. If you as a GP have a CT scan that said, there's a suspicion of a pancreas mass, or there's a dilated duct pancreatic duct suggesting there may be a tumor here, anything like this, then we're actually happy to take referrals directly from GPs in Swansea. We have done on a number of occasions, and it cuts out the middleman a little bit. It does upset some of the local MDTs when we are when we don't go through them, but it's actually what's better for the patient. It's possible to get people. I've certainly managed to get people through from seeing their GP with a bit of abdominal discomfort through to having surgery in under 3 weeks, just because they came through as a direct referral. So I've got no problem with that at all. We talked about RDCs. I think that the RDCs are a really great mechanism for getting these patients through. As you can see, 10% cancer conversion rate. That's better than most screening tests. In terms of also improving the general health of the population, nearly 50% of patients coming through an RDC will have some sort of new diagnosis that needed sorting out. So it's definitely a worthwhile resource to use, I think. We've also talked briefly about Jessica's law, Jessica's rule. I mean, I think that's again important. We, as an MDT, often see patients who've had major delays in their treatment pathway. Sometimes, and we're dealing with a guy at the moment who I saw in clinic in the end of September, who had an initial scan that was suspicious of malignancy in May. He's now got metastatic disease and he's going off to have chemotherapy, but it's taken him that long to get through the system for various reasons. There was some unclear reporting on the first scan. It then took a while. He went to a colorectal surgeon after that and a few other things. And there's frequently delays like this. In this case, this lady's case, obviously that's not the same situation. She was repeatedly presenting with unusual symptoms, but I think it's important to chase the diagnosis and not just write things off, particularly if people are coming back again and again. Screening for pancreas cancer. I mean, the evidence for screening is pretty poor. There isn't really any evidence, and the pickup rate is very, very low. There's no one single test available. I mean, that's I can remember at medical school being taught the elements of a good screening program. One of them is a single easy test with a good positive predictive value that's agreeable to patients, and that's certainly not available for pancreas cancer. We do a lot of cyst surveillance in pancreatic unit as well. So we follow up all patients who have pancreatic cysts. So we're happy to get referrals for those as well. Often there's a spectrum of cysts, but some are generally pancreatic cysts are associated with developing malignancy in the future. So we know that these are a group of patients that we can pick up who, if we follow them up, hopefully will make some difference to their pathway should they develop a cancer in the future. As I said, there's no evidence for screening for pancreatic cancer at the moment. There's a trial that's run out of Liverpool at the moment called the EuroPac study, which is trying to develop an evidence base for this. They've been trying for about 20, 30 years, and I'm not sure how far they've got at the moment, but it is a good program, and they are at least collating all the data for these patients that we're screening. You can refer, patients can self-refer, and I encourage patients to self-refer as the screening process itself is fairly grueling, and patients have to be pretty committed to they have to really want this to follow through with it, I think, and I'll explain why in a minute. Anyone with the 2 first-degree relatives on the same side with the cancer, anyone with a recognized predisposition, something like the previous cancer syndromes we talked about already, the SPINK mutations, CDKN2A, which is the FAM syndrome, BRCA2, PRSS, which is hereditary pancreatitis, and also a single case of pancreas cancer in their family. Anyone with Peutz-Jeghers syndrome, they're particularly at risk. And the screening protocol consists of a baseline CT and then annual endoscopic ultrasounds after that. So anyone who's had an endoscopy and endoscopic ultrasounds, the next level up from that. It's a big old scope to swallow, and a lot of patients don't make it more than through 1 or 2 of those before they decide, actually, this is I don't really want to do this anymore. So it's it's for a committed patient. So ultimately, as I said, it's the key to speed through the pathway. We talked about timely referrals already. This is conscientious, this is contentious, avoiding gatekeeper local MDT discussions. We do find that local MDTs will often fully work up a patient before referring them to us and get a tissue diagnosis and everything. We don't need a tissue diagnosis to offer someone surgery. We need a CT scan that shows there's a head of pancreas mass, and we can pretty much take it from there and offer them surgery. So there's a lot of time is wasted, sometimes a month or more, going through local MDTs, them getting various scans done and everything else. That's what we're trying to avoid. All we need is a CT scan showing a suspicion, and we can take things from there. Our pathway as it runs, so from referral to MDT, the median length time of the pathway from us receiving the referral to discussing them is 7 days. From MDT discussion to seeing them in the cancer clinic and talking to them about what they need, then that's another 8 days median. So we see people, within a week of discussing them in MDT, and we often will call them before they come to see us to let them know that they may be expecting tests and things, and we try and block book their investigations, things like PET scan, things like EUS if we need tissue, or MRIs and things, and we try and get the ball rolling for them as quickly as possible. We have a team of 3 clinical nurse specialists in Morriston, and it's their job basically to look after these patients and arrange their tests, chase the results, try and move them through the system as fast as possible, really. To be able to do that, it's difficult in Wales. A lot of the health boards are really struggling with radiology reporting or access to scanners even. So there are currently some of the health boards are taking up to a month to report a USC scan, which is difficult when you're trying to move people through this. Endoscopic ultrasound is becoming increasingly key in pancreas cancer diagnosis. We use it for tissue acquisition prior to, if we've got patients with locally advanced disease or borderline resectable disease, that means that there's vessel involvement. Those patients we now give, rather than doing a trial dissection straight out, we tend to give them chemotherapy up front for 6 months prior to resection, because that gives better outcomes long term. And for that, we need more EUS. Unfortunately, the capacity is just not there. And then that led to another layer of delay in terms of histopathology reporting. And again, it can take several weeks sometimes to get the results back after the biopsy. So all of these, it's a week here, 2 weeks here, 3 weeks here, and it all suddenly adds up to that 90 days. You can start to see where it all comes from. And so the aim of the pathway is to try and compress all that. And if we can shave off a couple of weeks off the beginning of it by referring directly, then that's helpful. Even if it's not referring directly, it's at least not waiting for the local encouraging the local secondary care consultants to refer to us rather than waiting for their local MDT to tell them to refer to us. The pathway is very simple. I don't know if you probably can't see my. There's the blue box after the row of dots at the top of the various are the various ways patients can enter into the pathway. We then have your basic CT scan, and that goes to the yellow triangle, which is a decision breaker for does the patient have evidence of metastatic disease or not. If they have metastatic disease, they go to the blue box, which goes to the little green diamond, which takes you down the palliative care path. Because if they've got metastatic disease, surgery isn't going to be an option. They may well still have access to chemotherapy, and palliative chemotherapy can be very helpful, but they're not going to be going down the radical treatment pathway. The radical treatment pathway takes them through the big green diamond here, which is an MDT discussion, and down through then the decision as to whether or not they'll need a neoadjuvant pathway or whether they'll go through straight to surgery. You can see down the left-hand side here is a time scale. My desire for this pathway was for us to get patients from first referral, first presentation to definitive treatment in 28 days. Unfortunately, that doesn't agree with the Welsh Government's targets for cancers, which says everything has to be done in 62 days. So that's why there's a... I'm sorry?
It's right, Guy. I think someone's not on mute, but I will try and keep an eye on that.
Thank you. So I thought someone was asking a question. And then this orange square here is another sort of 28 days that I think we had to add on to take it up to closer to the 62-day target. But ideally, patients should be, in my eyes, getting their treatment within a month. That's conscientious. It will cost a lot of money to do that because you need to enhance all of this diagnostic capacity to be able to get these patients through faster. In terms of treatment capacity for surgery, we are okay at the moment. I saw a patient in clinic on Monday who I'll be operating on the first week of November. So that's, we're getting people through fairly rapidly. And that gives us time to get her PET scan back, get her pre-assessment done with the anaesthetist and all the rest of it. Oncology, again, seem to be getting people through fairly quickly. And that's reflected in our surgical outcomes. I had a nice slide, which was the only good news really in my talk, which was about the surgical outcomes. Referring back to the NAPCA audit, in Wales, our 30-day survival or 90-day survival post-surgery is 100% in the last 2 years versus 95% in England, which is good. So none of our patients died in that time. That's about 50 patients went through without mortality. And our 1 year survival, I think, was 82% versus 72% in England. So that in one thing we are kicking goals is in surgical care of these patients. But as I said to you, that's only 15% of the people coming through, and we need to be extending those gains to those patients as well, I think. And what I suspect part of it is that they come under our wing essentially when they come to see us, and they have access to the dietitians, they have access to oncologists, and access to our CNSs, and they probably get looked at a lot more closely than the patients who don't go through surgery, and that's something that I hopefully could change. Right. So what things can you do to help your patient as a general practitioner? One thing I think is really, really important is having a positive approach to patients. I mean, you can't tell them it's all going to be okay, because it's probably not going to be okay, but you can, as Ruth's already shown with her example of a patient, you can treat this disease. It's not curable, but it is very, very treatable. And a lot of the problems can be palliated fairly easily with fairly simple steps. to give good quality of life to these patients. And I think it's about how you frame the information that you're giving them and how you respond to things. It does have an impact on how patients view their disease. And I think that's really, really important. I've said there just about encouraging activity. The number of patients I see who seem to have just been, their family just want to keep them cooped up in the living room almost, it seems like. They've stopped going out, they stopped seeing people, they stopped doing things. And it's almost like they need permission to go out and be active and do things again. And I think it's really important to just, if they have got a limited time, if they're able to, they need to be just getting on and doing things that they want to. A little bit about pruritus, about itching and jaundice. A lot of people I see come to us on Piriton for itching, and it helps them sleep at night, but beyond that, it doesn't do a lot. ERCP and stenting requires an inpatient stay in most patients. So if you've got a patient with jaundice, you probably, certainly in Swansea, you're going to have to refer them in acutely to get them sorted out. There is no, certainly with us, we don't have any access to outpatient ERCP at the moment. So any patients who have that, you just need to send them in on the acute take. Unfortunately, bringing them along to an outpatient clinic doesn't do them any favors, because it'll take them a couple of weeks to get there, and they're just going to get more and more yellow. So I think in most of the time, discuss with your secondary care provider if you've got someone with obstructive jaundice and a suspected cancer, they need to come in. Also, there are those patients who've already had a stent placed and their stents got blocked and they're going yellow again. Usually they'll notice that their wee's gone a bit dark to start with before they start to get on their pales. Stools have gone a bit pale before they even notice they're going yellow. That's a bit of an emergency, because once you've installed a stent in someone, it does act as a two-way street, and there will be bacteria climbing up the stent as well as bile coming down the stent. So they are at risk of cholangitis, and that stent needs to be changed or replaced if it's blocked, because it will be infected. Though all the stents are colonized with all sorts of wonderful things. Pain control. Again, I think it is best managed by someone who has regular access and it's easy for them to see the patient, and they will be following them up. I do occasionally get patients who say, "Oh, that they didn't want to give me anything until they'd seen you," and I'm like, well, I'm just not sure about that. I think it's really important to manage people's pain and symptoms early on, and it's probably not for me to be starting MST or morphine in the outpatient clinic when I'm not going to be following them up again afterwards, and they're going to be going back. So usually I personally would send people back to the general practitioner for that. The other thing that's really important with pain control, again, as Ruth showed in her example, is ensuring that their exocrine failure is being managed. If the bowels really, really dislike having undigested fat going through them, and if you can, and that gives people pain, it gives people bloating, they get terrible colic. But if you can just sort out their exocrine failure with some enzyme replacement, a lot of those symptoms will go away and they can get them off opiates again. We see this loads in patients with chronic pancreatitis who will be on 100 milligrams of MST twice a day, loads of pain, loads of symptoms. You get them established on the enzyme replacement therapy and they can manage on paracetamol. So it's really important to get that underway. The other thing is, if you are struggling in the community with managing people's pain with opiates, celiac plexus blocks are really, really effective, and that's something that we can offer. Usually we do them by endoscopic ultrasound, but I believe the anaesthetists also do it percutaneously as well. I think EUS is probably more straightforward to do, because you can visualize the celiac artery, inject local anesthetic and alcohol around it, and it just burns all the nerves away, and they feel much better straight away. Hannah has already given us an excellent talk on PERT, so I'm not going to go on to that again. And as I said, the thing I see a lot of is fat avoidance. So as she said, people are already masking, they've already given up eating fat, and it's important to ask them, if they haven't got much of the way of symptoms, what things do you avoid? What food don't you eat? And they'll usually say, I can't have cream cakes and pastries anymore. And you're like, why is that? Oh, because I get pain and bloating. So I think it's important to check on that. Diabetes. Patients with a pancreas replaced by tumor, or because the pancreas duct is blocked, the pancreas upstream becomes atrophic and doesn't work properly anymore, they develop type 3C diabetes. Either I create it with an operation, or it happens because of the tumor process, the cancer process, and they have a loss of the pancreatic tissue. And it's difficult to treat because it's combined exocrine and endocrine failure. So as Ruth already said, checking the HbA1c and fasting glucose early on is really important. First line management is with metformin, and then add on insulin to that if that fails. And if you're struggling, if you're finding that difficult, you're struggling with that, then speak to the endocrinology team. But again, the problem with referring to secondary care for this is that they are, it will take quite a long time to get the patients referred across there. Poor control is really important because it essentially drives the weight loss. So if the people are walking around the blood sugars of 20, they will be losing weight, as you would see with someone with a new presentation of type 1 diabetes. And it's clearly shown to worsen outcomes in pancreatic cancer. It drives the disease process. So it's really important to get on top of their diabetes. They also can't have an operation if they've got ridiculously high blood sugars. We have to get that under control before we can treat them. Okay. The other thing to say is if you're managing the exocrine insufficiency well, you may have already stabilized their diabetes, but when you start them on the creon, you may also notice that their blood sugars then become unstable again, and there is a balance sometimes. You may find that things get worse as they start eating properly again and resume normal diet. Referrals that should be made. We've already talked about dietetics referrals. That's really important. Oncology referrals, palliative care referrals. I'm not suggesting that you need to refer every single patient that you see to these, but I think in your job as an advocate for your patient, if you see that these things aren't happening as quickly as you think they should be, or you think the patients, then pick up the phone and contact and find out what's going on, and just make sure that these referrals have been done. You know, patients frequently fall through the net because patients are discharged from secondary care, they go back into the community, and sometimes they get forgotten about. And we certainly, again, see that they're just not necessarily followed up as well as they should be. So I think as a GP, it's hopefully you're in a position where to be able to spot these patients if they come to see you and say, well, I haven't heard from the hospital for a month. And I think all I'm saying is just don't assume that everything's in place. If you have time to, which you may not do, if you do have time to check on these things, it's helpful. In terms of signposting patients, Macmillan Cancer Support are excellent. And we've already also spoken about how Pancreatic Cancer UK provide excellent advice, both for patients and for clinicians. I noticed recently they've got a web-based education module now for the management of type 3C diabetes, which is probably something I'm going to do because I think I need to know a bit more about it. And there isn't a lot of literature out there on it, to be honest. So I think that's probably worth looking at. It's free, which is always good. And I think they give you CPD points for it. So in summary, we've got a pathway. That's great, but there isn't necessarily the investment behind it to make it work as we should do at the moment. And I don't know if that's coming or not at the moment. None of what I've suggested is hugely complicated, but it does take time and it does take effort to get these things together. We are not always right in secondary care, and we frequently miss things. And most importantly, you are in a great position to be an advocate and make a big difference to your patient's experience, as again Ruth has already said in her examples. Okay, any questions, please?
Thanks so much, Guy, Hannah, and Ruth. Really inspirational, really informative, and I mean, I didn't even look after patients with pancreatic cancer. I do when I'm on call, but my day job is looking after people with lung cancer. A lot of similarities, but it's been really informative. Thank you. Just while we're thinking of questions, if I can just fill a moment, I think just want to reinforce what Guy said there at the end, a really important point that, picking up the phone and talking to a colleague, actually having a conversation, clinician to clinician, is so important. So rewarding when that happens. I know it's a little bit difficult. There are barriers in terms of time, communication and things, but, please do advocate for your patients, pick up the phone, talk. I've come to realise that, I'm not sure what the right word is, but the transition points, you know, when a person goes from a person to a patient, or a patient becomes a cancer patient, where you go from curative to palliative, or active treatment to end of life care, or primary to secondary care, or secondary care back to primary care, those points of vulnerable points in healthcare and things often kind of could be better. So those are where we need to attend a little bit more and just be a little bit careful if anything's getting a bit sticky for the patient, then be our advocate, exactly like you say, Guy, and, you know, make sure they're getting the best care that we can. Fiona, you've got your hand up, and then Guy, I'll go quiet.
Really, really quickly, from a palliative care point of view, and this is fantastic information, thanks to all the speakers, just really putting a punt for the palliative care team, but actually just please don't feel afraid just to ring up for advice. So just thinking around that pain control issue, particularly, sometimes this is really funny pain. People find it hard to describe and think where that tumour is. So occasionally, for example, some neuropathic pain agents can be helpful, but you don't necessarily need, the patient may not necessarily need the whole of the specialist palliative care team. So if you're at all unsure, just ring up and talk to us and we can give advice over the phone. Because I think, Guy, your point about pain control being something that actually it needs to be reviewed by people who are looking after the patient regularly. And it's quite possible, if things are settling down, that the doses of opioids, of course, get smaller if you need opioids at all. And my last thing about typical me, that pain thing, if there's exocrine failure and people have got constipation, bowel spasm, they're going to get that different sort of abdominal pain, which will respond to different medications. So it's about just disentangling all of that. But thank you. I found this evening really, really interesting. I'll shut up now as well in terms of time.
Guy, do you want to come in?
Yeah, the other thing I wanted to say was just to highlight, this is the email address here, sbu.pancreas@wales.nhs.uk. That is our monitored sort of helpline email address. Patients email it, you know, doctors email it, the other CNSs email it. That's manned by our pancreatic CNSs. If you need to get hold of someone, you've got a question, you don't know what's going on, you want to find out, you know, what's happening with someone, or you've got a patient, you're not sure if they've been referred to us or not, or anything like that, if you drop a line to that email address, they will sort you out. Okay, that's it's run by it's Lisa, Renee, and Melanie, and they are all excellent at what they do. And all of the patients who've been through us in clinic, have access to them, so they'll have been given their details. So that's, you know, a significant proportion of the patients. So all the patients with locally advanced disease, borderline disease, or resectable disease who've been through us, and in Swansea Bay, the ones with metastatic disease as well, will have all been introduced to them, and will have their details to call them at any time if they need to. There is a phone number as well, but I think the email is probably easier.
Perfect. Well, you know, again, thanks to everyone who has spoken today. You know, all three presenters, Ruth, Guy, and Hannah, you've really delivered something that's really valuable to primary care. I think, you know, we've shown that despite the IT glitches, we've gone 15 minutes over. So I think there's lots to talk about. And